Well, good afternoon, everybody. My name is Francisco. I'm the Director of Global Marketing, Pancreatic and Hepatology. Before we start, I would like to congratulate the Orlando Health team for such an outstanding meeting, from the program, the faculty, the cases, and the organization as well. I don't think you can get better than this. So congratulations again for such a great program. It is with great pleasure that I welcome you to this Medtronic Lunch Symposium, Pancreatic Cancer, Finding Biopsy, and Beyond. On this session, we'll have a multidisciplinary panel of well-recognized experts. Dr. Niraj Jhala, Professor, Pathology and Laboratory Medicine Director, Anatomic Pathology Cytology at Temple University Hospital. Dr. Neil Jarma, Director, Interventional Endoscopic Oncology and Surgical Endoscopy, also is the President of the Parkview Cancer Institute at Fort Wayne, Indiana. Dr. Paolo Annoletti is a board-certified surgical oncologist with the Orlando Health Center, and he's the Chief of Surgical Oncology. Dr. Wasif Saif, board-certified medical oncologist, is the Deputy Director of the Cancer Institute at Orlando Health, and also Department Chair for Hematology and Oncology. So without further ado, I pass it to you, Dr. V, to moderate the session. Thank you very much.
Thanks for joining us through your lunch. So this is a real-life situation of pancreatic cancer, how we struggle with the diagnosis. And this panel is very close to me. We met, three of us in this panel met as assistant professors in Alabama in the early 2000s. And everybody is simply fantastic. I think Wasif Saif has published close to 800 manuscripts, mostly on pancreatic cancer. Arnalati has dealt with all my complications and has done all my surgeries. And Niraj Jhala is my go-to person for pathology. I think he's the best pancreatic pathologist in the world. And Neil Sharma is like me. He does procedures, and we turn to these guys when we are in trouble. So without much ado, we will start our case. I thought I will split this lecture, the next 20 minutes, into 3 sections. How do we get the best tissue for pancreatic diagnosis? Let's face it, when we do FNAs and FNBs these days, we get a diagnosis 95 to 98% of the time. 2% of the time, we have a problem. Second, what happens when we get as much tissue as we can and the pathology is still indeterminate? The patient can go for surgery, can go for chemotherapy, and our referring doctors are unhappy with us. And finally, I thought we should get educated on precision medicine in pancreatic cancer. I don't know much about precision medicine in all honesty, but I think the rate of survival in pancreatic cancer has moved 5-year survival from 5% to 11%. So there was a time we never believed in chemotherapy, but it looks like our oncologists really have some drugs that work these days. So with that as background, this is a patient who came to me about 400 miles away, and I think the referring physician is actually with us today. So this was a 44-year-old male who had a 45-pound weight loss and persistent abdominal pain for 3 years. This patient had been smoking and I wouldn't say abusing alcohol because I might fall into that category for almost 15 years. He is not a diabetic. He had 14 CT scans, 10 MRIs, 4 EUS-guided biopsies over 3 years. And the working diagnosis was chronic pancreatitis. He was referred back because he had severe pain, and the gastroenterologist told me, something is not right about this patient, take a look. There's an MRI that you can see, and you will see that the distal pancreatic duct from body onwards is very dilated, and you don't see anything more proximally. So this is the information that I have. So I'm going to ask Neil to answer these 7 questions that is in front. Which area, when you get a imaging like this, Neil, there's no mass. You just see some sort of a ductal dilation and nothing is seen. Which area of the pancreas would you target?
Yeah, it's quite difficult. I think if there's not a discrete mass in the pancreas, then when you're looking with the EUS, we look for transitions in the duct. So that would be really important. So that could be transitions in the pancreatic duct where it narrows out and dilates distal to that, or areas where the bile duct, if you're presuming the cancer's in the head of the pancreas, has some focal narrowing or thickening. So that would be what I would look for on EUS.
So one thing that will always bother me is if I accidentally puncture a duct with a FNB needle, will I cause a leak? I don't have evidence again. For a pancreatic duct, if I see these patients, particularly, I give them rectal indomethacin and I open up the IV fluids. No data if it will help the patient, but that's true. Second, bile duct is a little bit of a challenge, but it's my own, correct me if I'm wrong. If we sample the bile duct very close to the mass, inadvertent puncture does not cause bile leak. That inflammation seals the leak. You agree?
Yes, absolutely.
And what needle would you choose for these patients?
Yeah, so this is something that I do every day, to be quite honest with you. And so we do multiple pancreatic cancers. We typically use a 22 gauge core needle. And we found that we're doing that for FNB, we get adequate tissue samples.
And is there a particular technique that you will adopt?
Yeah, so we've played around with this quite a bit. We use a slow pull technique with a stylet. We've tried, actually, we had a study that we tried to randomize between that and doing some suction. But it did not really necessarily make a major difference. And I think the reason why is if you get adequate true FNB with the coring needles, you do a touch prep, for the most part, the statistical differences between small amounts doesn't make too much of a difference. So that's typically what we use as a slow pull technique.
And do you use ROSE in your practice?
Absolutely. Every day.
We are a strong proponent of ROSE. If we don't have rapid on-site assessment, I don't know what I would do. And Dr. Jala has actually traveled with me more than 15,000 miles for one particular procedure because I would not leave, no matter who the patient is, without a very good pathologist with me. How many passes will you perform?
Yeah, typically what we're doing is actuations. So when we say actuations, we puncture the targeted area. We're going back and forth. We want very fast movements forward because these are cutting on the way in. So there's a lot of trajectory and slow movement back. That usually ends up being somewhere between 6 to 8 before the stylet's almost out. Passes, we usually do 1 to 3. Typically, it's usually at least 2 because we like to save tissue in formalin for molecular analysis. And just a point on the rows, we're doing a touch prep, right? So initially, all of us who are doing FNAs, we want to take tissue, smear it, get cells, and create a cell block. But here now we're trying to keep tissue architecture, so we're using a touch prep. And we find that really valuable. And I think in the world of oncology right now, it's important to understand also what's available to you for radiation oncologists. And so we can't just be technicians. Our radiation oncologists will add SBRT for locally advanced pancreatic cancer. So if I have an answer from a cytopathologist, I'll place fiducials in the same setting, which saves the patient an additional procedure, which is also an advantage to the ROSE.
Nirag, you're happy with us getting all the specimen in formalin?
So formalin is good, but I generally like it in a Hanks balanced salt solution if there is no ROSE. The reason is that if at all there are lymphocytes in there, then Hanks balanced salt solution will preserve some lymphocytes till the time we see it the next day. If it is pancreatic cancer, in this case you are saying chronic pancreatitis, so we are talking about epithelial lesion. But if there is a concern for lymphoma, and if you are going to just take the core biopsy and send it in formalin, you lose the opportunity to do flow cytometry.
So if you can translate it to this is an endoscopy audience, so keep it simple. So if there's one solution we have to use, HBSS is the correct solution?
That's what I would prefer, and ask the lab to process it as best as they can and as fast as they can.
As fast as they can. If this patient comes at 4 p.m. in the evening and the lab is off Saturday and Sunday, will HBSS be okay to preserve the tissue?
No, then I would just put it in formalin in the evening time.
Can you give us a lifeline on how long the specimen can be kept in HBSS? How long can the specimen stay in Hanks solution?
So in Hanks solution, up to 18 hours, everything should be okay. After that, the lymphocytes will start going away and you can't do flow on there.
This is just a brief update on one of the studies that we performed. If you use the 3rd generation biopsy needle, you can get very good cellularity. When I say cellularity, the amount of cancer in a histological tissue is very, very high for the third generation FNB needles compared to the conventional needles or the FNA needles. And you can see diagnostic accuracy with a single pass can be 100%. But take this message with a tinge of salt. It's done by experts. We got very good support. So you should at least perform a minimum of 2 biopsies if you don't have a pathologist. But such are the good outcomes with the new generation needles these days. So now I'm going to go back to this case because I recorded this particular procedure. So we are doing a pull through, and as I'm coming down, I think this is somewhere in the neck region. I'm performing my first pass. I thought, well, the dark area is the pancreatic duct. There's a soft tissue that is occluding the duct in that region. All benign cells. I mean, I'm not a pathologist, but to me, if these cells are looking, it's benign. So now can do the same thing over and over. So now I've tried to move the needle in a different location in the same area. And I thought maybe I'll fan it. I got these, and my cytotech is pretty good. He said, this is the only group I have. It looks a little atypical to me. Keep going. So now the second pass didn't get anything. So I thought, well, I knew that we are having this conference. So I thought I should get this case, label it for you. And that is the only mass I could see at that particular region. So I'm performing my third pass. All benign. So now you have to change strategy. This is not working. So I thought, well, let me move into the duodenum. The patient had mild increase in LFTs, but really was not obstructed. I see the common bile duct. I see some sort of a thickening. Then I thought, well, maybe I need to go here. It was really not a classic double duct sign. And then I went into this area to see if it makes some changes. So Nirag has always told me how to interpret these slides. Goldfish with a shark. On the left is all uniform fish. And then on the right side of the screen, this does not look good. And it tells you when you see this, you're smelling blood. You have to go after this place over and over. But we don't have you in our practice every day. It was called suspicious, and that's as high as it would go. Now, this is indeterminate pathology. Now, oncologist is never happy with suspicious. What they will do is, if you're not giving them a diagnosis, they go elsewhere. It does not matter how good you are. It really depends on who's interpreting the slide. So there are only 4 options we have here. So let me have the first option. Neil, do you think we should repeat this, bring this patient once again? Because I've done about 9 passes in this. My jar is full of core tissue. Should I repeat the EUS?
I typically would repeat the EUS.
Pablo, time to call you and say, open up and get us a surgical biopsy?
Correct. So the 2 scenarios. One, if this is a suspicious enough lesion with significant risk factors and a resectable tumor, or a resectable area of the pancreas, and the lack of vascular invasion, then we would resect it and tell the patient that if this ends not being pancreatic cancer, then he'd be very lucky. The challenge is the patients with tumors or areas that are not resectable, who present with encasement of the major vessels, occlusion of the portal vein, cannot be resected, and therefore we have to rely on a biopsy. Personally, we're very fortunate to work with outstanding endoscopists. I typically ask them to biopsy it twice, and after 2 strikes, we usually take them for a laparoscopic exploration and biopsy to try to establish a diagnosis, if not resectable.
A friendly audience, trust me, they will be willing to listen to the truth. Are there surgeons these days who will really take patients to the operating room and get us a surgical biopsy? I hear surgeons saying, yep, no problem, I'll do a surgical biopsy, but they never take patients to the operating room for a surgical biopsy. Does it happen?
It does, and we do now for lesions that are in the body or tail. That can be difficult because the risk of pancreatic leak is significant. And the lesions in the head, we do a transduodenal biopsy. But otherwise, we look for other peritoneal or liver tumors or implants. If there are ascites, we sample that and try to establish a diagnosis also by looking outside the pancreas and maximizing their efforts to settle a tissue diagnosis. Again, in the setting of a tumor or an area in the pancreas that's not resectable.
So in my practice, it's very simple at least. I bother Dr. Jala. What I do is I call him and I tell my unit, send the slides to him right away. So when we send slides for interpretation, what should we send? Should we just send you the slides? Should we send you the specimen and formalin so that you can do something more? What do you what do you expect from an outside pathologist or a gastroenterologist seeking a second opinion on a slide?
So slides can be processed at site, and you can send us unstained slides along with it. So stained slide and unstained slides together. If it is an atypia, there are two stains. So I had shown in my lecture yesterday that you can do either mesothelin or SMAD4. Combination helps. SMAD4 alone doesn't help because SMAD4 can be positive in pancreatic carcinoma as well. But if you have negative SMAD4 and positive mesothelin stain, both are immunohistochemical stains. So that would help us confirm our suspicion. So that is possible.
So when my impression was when we send specimen to the lab, there is nothing called unstained. I thought they stained them all, section. Are there slides kept unstained?
So when you have a cell block or a surgical, so FNB that you have, you will be able to get at least 25 to 30 unstained slides. That is possible from there. So if you have them available, you can ask them to cut the unstained slides. Immunohistochemical stain can be performed. If you have a cytology sample and it is still in the vial, you can actually also do fish analysis, similar to what they do for the urine samples. It's a four or multi-probe fish that can be performed, and if there is polysomy, then that is associated with carcinoma.
Simple question. If you're not seeing cancer cells, you're seeing the cells that I showed you, there is other markers that you will use to definitively give us a diagnosis of pancreatic cancer, or will you tell us highly suspicious for pancreatic cancer?
Okay, you can't take suspicious away from a pathologist. We lose. But having said that, if we are really suspicious on H&E that this is going to be cancer, but I can't call it. So in that scenario, if you have these two markers, then you can go over the hump and say, okay, this is positive, then I'm fairly confident this is carcinoma. So that is something that to push you over. In this scenario, the group that you showed is looking like carcinoma actually. But if you have FNB and if you are still suspicious, you can use those two markers.
So for full transparency, I did send you that slide and you did call it cancer. So Vasif, are we guys wasting, I think you're feeling too comfortable. Are we wasting our time with pathology? Is there a miracle blood test that is serological blood test that is available? Because we read journals that we don't understand sometimes, and I just flip through the pages. Are there some other form of serological testing that is showing promise for diagnosis without sticking a needle?
I think for us, I think the key element is that, I definitely need diagnostic.
You have to get closer to the microphone.
Of the, pathology. Because suspicion does not allow me to give systemic chemotherapy to our patients. So I will be calling back the pathologist and say, please relook at the specimen. If they are not able to confirm, suspicion does not help me, then I probably will be calling you and asking you to repeat the biopsy. But I think for a medical oncologist to give systemic chemotherapy, not only we need the tissue diagnosis as a confirmation, but also keeping in mind that we need to know the next generation sequencing in pancreatic cancer to triage the right targeted therapy. So I think for my job to start, I need confirmation of tissue diagnosis with an extra tissue to be sent for next generation sequencing.
Okay. I want to move next to this. There was some sort of an audience questions that we had asked. I forgot to ask, but it looks like people wanted biomarkers for diagnosis. That's fine. So I want to move on to this next chapter, which appears to be very important about the future of our technology, precision medicine. How close and how good is precision medicine? Is this something that we all as gastroenterologists should routinely practice in in our clinical endoscopy in 2023? Or this is something that is localized to expert centers?
Right now, NCCN guidelines really recommends that every patient with pancreatic cancer, irrespective of stage, should be tested for next generation sequencing. It is very important to understand this part that most of the insurance companies are also willing to pay for it. The reason why we need molecular profiling of the pancreatic cancer is very simple, as I mentioned earlier. We need to really triage the targeted therapy for pancreatic cancer. We also need to match the patient to a clinical trial. Keeping in mind that precision oncology really has revolutionized the treatment of cancer patients in most solid tumors. Pancreatic cancer is running behind, but still coming in the right direction. Not only it allows us to give the right therapy to the patient, but also allows to prevent the therapy that may be causing a lot of side effects. We also are still not able to pick up the right chemotherapy for the patient. So molecular profiling, hopefully in future, will help us out what chemotherapy to be picked up for patient with pancreatic cancer. For example, we are really dealing with two regimens for pancreatic cancer. One is the FOLFIRINOX, which is a fluoropyrimidine, oxaliplatin, irinotecan, and the second is the gemcitabine-based therapy with nab-paclitaxel. We still don't know which regimen to be used in patient, except patient's preference, side effects, and also performance status. But now the molecular profiling may be able to help us to look at some biomarkers such as GATA-C, GATA-6 biomarker profiling by immunohistochemistry, showing that patient with a low GATA-6 may not respond very well to fluoropyrimidine-based therapy like FOLFIRINOX. On the other hand, patient who receive GemSAR-based therapy may not have any impact. At the same time, it also imparts the prognosis on these patients. So I think we're definitely going in the right direction. The speed is a little slower for pancreatic cancer compared to other solid tumors.
I always love to have you in the panel because everybody complains I speak fast, but I have competition with Vasif. So this survival, is this survival uniformly good for every stage, or have you made good progress for every single stage, or is it only in some stages survival has improved?
So the good news is that, in 2023, if you look at the ECS facts and figures, the 5-year survival has now improved to 12%. This is the second year in a row that we are improving the survival of 5 years by 1%. I think that's a good news. If you look at the further data, if you go to the PanCan website and look at Know Your Tumor, it has been shown that tumors with pancreatic cancer, patients with any stage with pancreatic cancer, if they don't have any actionable abnormalities, their outcome is about 1.31 years. If the patient has some actionable mutations, but they're not given the targeted therapy, their outcome is about 2.32 years. 1.51 years. But patients who have targetable mutations or abnormalities, and they're given those medicine, actually their survival is 2.32 years, which really means that patients who have targetable abnormalities, mutations, these patients can benefit, not in terms of effective therapy with improvement in survival, but quality of life. So I think right now the clinical trials for pancreatic cancer in different stages, including resectable, borderline, locally advanced and metastatic, they're all looking for these targetable, mutations, genes to really help us to go for the future therapy. So I think in a simple word, the survival in the pancreatic cancer has improved from less than 5% when I was a fellow to 12% as of today. At the same time, patients with actionable mutations, and if they're given those therapies, their outcome is much better than the general survival for pancreatic cancer, reaching about 2.32 years, which is outstanding.
Thank you. Nirag, nowadays when we do biopsies, if we do rows and we have a tissue, we always do a pass and cell block and we are done. Has things changed with precision medicine? Do you want to see a specific number of biopsies for molecular profiling that will give you enough tissue for guaranteed testing, whatever you need to do in the lab?
So what we have seen for the lung tumors as well as for pancreatic tumors, that if we have additional 2 passes, once the diagnosis is made, then we are able to provide the next-gen sequencing on these samples. So only 2 would be enough. And there are a number of different panels that can be used. So you can either use 65 gene panel or you can use 500 gene panel. And that you can do it through just 2
One more clarification. So if I have rows, Because let me be very honest, sometimes no matter what we give you, we get this final answer, insufficient. Okay, so how much do you need definitely for diagnosis, ROS is positive or whatever? Do you want 2 dedicated passes in cell block for additional testing and then 2 passes for molecular profiling, or you just need only 2 for everything?
So on ROS, if you have called it carcinoma, we are not going to go back.
I don't know about that.
Generally, we don't go back. Okay. So once you have that certainty that you are dealing with a carcinoma, then the triage would be additional 4 passes. You put 2 for cell block and 2 for molecular testing. So maximum 6 or 7 passes and you're done. Because generally, looking at this conference, and everybody would agree that 1 pass or maybe 2, and most of the samples we saw yesterday had enough material. 2 for those. Once we make the diagnosis, 2 for cell block and 2 for molecular testing.
So this is very important message. So if you look at my previous manuscript where we have published that with 1 pass we get more than 90% diagnosis and so on, I think in real life we need to perform 4 passes. That this is my experience, because let's face it, if we get a patient coming to us and we give them some diagnosis and we tell them, yeah, it looks like cancer, and then you get a final pathology report that tells you maybe cancer, we lose that referral from our referring doctor forever. I think we should just take our time, perform 4 passes, 2 for cell block, 2 for molecular profiling. I think that is golden. And let me go back to the slide. So we have done this study, and Nirag was a consultant on the study, and it's very simple. We thought, is there a difference between 2 or 3 passes for molecular profiling? And it looks like if you perform 2 passes, stylet retraction, if you fan the needle adequately, you will get enough tissue for performing all RNA and DNA mutations that will be required. And I don't know much about oncology, but then again, if it is a BRCA1, apparently you can do cisplatin-based chemotherapy, which is very different. And this will impact patient outcomes, right, Vasuf?
Exactly.
Who can request molecular profiling these days? Because I thought I can request, and I was told, no, you can request. It has to come from the oncologist. Is that right?
That's a very complex question. It's not that easy because there are guidelines from CMS, which is the Center for Medicare Medicaid Services. So the CMS requires treating physician to order the molecular profiling. Keep in mind that some institutions work in a way where the pathologist can order those molecular profiling as long as they list the treating physician as well as also confirm from the treating physician. But at this time, the requirement is really that the treating oncologist or a surgeon, whoever, should be requesting the molecular profiling.
And is molecular profiling reimbursed? If we order it, does all the insurance, Medicare and all the private carriers reimburse for that?
As you know that we really try to follow some national guidelines, and the NCCN guidelines mandates or recommends testing the NGS in pancreatic cancer. So in general, most of the insurance companies allow to have this molecular testing done. At the same time, about 1.5 years ago, FDA also recommended and allowed most of the solid tumors to have the NGS testing. Keep in mind that when we are ordering these things, we have to use special codes. Historically, we are so used to use the CPT codes, but now we're also using Z codes. They create the Z code 0, Z01, V0, I believe that's the Z code they use for Caris, for example. So now there are Z codes and the CPT code. They're trying to utilize those one for the payment. The MolDX, which is a molecular diagnostic, national panel, they really look at those things on an annual basis, and the cost in general for a molecular profiling is around $3,500 for one time. So definitely, this is something that we are able to get it done. I would say that if there are 100 patients we request a year, hardly 2 patients will be declined, and then we go back and fight, and then we're able to get them reimbursed for those patients.
So for the international audience, because we have 62 folks from outside the United States, molecular profiling is available in most countries. You just have to look around and shop around. Usually our oncologist will tell you. So I went to India this time and I was asked about molecular profiling, and everybody said, yeah, we do it. And the charge in India was actually something like $80. $80. So yeah, every country has got molecular profiling available. I think Foundation 1 is about 500 gene mutations they check for, But apparently there is no treatment for all mutations. It's just available. It's only about 60 mutations for which it's clinically relevant. And most countries have this, this testing for these 60 mutations because it is just not practicing US. We have to distinguish ourselves from everybody else in the community. And we have to do something more than what an average person will perform. And that is what will separate us as expert endosonographers. So I would encourage those of you who are not doing to take this because it has a lot of meaningful impact for our clinical outcomes for our patient. I think I've covered most topics, but all of you are experts. And do you have, each of you, words of wisdom on pancreatic cancer that I have not addressed, which is important? Pablo? Just share some words of wisdom that I have not addressed in this brief 20-minute summary that we should know about.
Well, I think one of the leading topics of this meeting is the interdisciplinary, multidisciplinary collaboration. And when we talk about molecular profiling of cancer, that's just another aspect that's routinely included in the discussion and the management of those patients. It has been added as part of the standard pathology report, and we're looking at doing universally in all the pancreatic cancer patients we see. But when you were asking about the order and physician, and Wasif was saying is a treating physician, and that's true, but it's the group altogether who discusses the patient with the collaboration from the pathologists, from the endoscopists, from the medical, surgical, and radiation oncologists. So it's a group of people caring for pancreatic cancer that results in that gives the better optimal outcome for the patients.
Let me ask you a difficult question. Are there any patients with pancreatic cancer that you operate, no matter what size, 2 millimeters, 20 millimeters, everybody is getting chemotherapy? Is there somebody who really goes to the operating room without neoadjuvant treatment these days?
There are some. The benefit of preoperative chemotherapy has been better demonstrated in patients with the borderline resectable group. Upfront resectable patients, which granted are a minority, we still operate on them up front. We saw a patient together with Wasif this past week. And in those patients, we don't have good or strong evidence to suggest that preoperative chemotherapy would help in their clinical outcome. Having said that, we believe that all patients with pancreatic cancer have systemic disease, at least so-called. So I think that very few or no patients can be treated with surgery alone. And the vast majority of patients require a systemic treatment either before or after surgery when they're resectable.
Wasif?
What Pablo said before I go to my piece of wisdom, I think we need to go back to historically looking at the adjuvant clinical trials for pancreatic cancer. The first clinical trial that really showed that not giving any adjuvant therapy is basically unethical is the CONCO 011 study that was done in Europe. In that clinical trial, they randomized patients to receive gemcitabine versus observation. They realized that in patients who are not receiving adjuvant therapy, the recurrence occurred within 7 to 9 months. Based on that one, when the ASPECT 2 and 3 clinical trials were performed, it was found to be unethical not to offer any adjuvant therapy to pancreatic cancer. As Pablo mentioned, this is a systemic disease. Unfortunately, even patients who get resected succumb to the metastasis. So I think just adding up a piece of evidence that at this time, hardly there's any patient, unless until they cannot tolerate chemotherapy, we offer adjuvant or neoadjuvant or peri-operative chemotherapy to all patients.
I know what Neeraj will ask us. More tissue.
Tissue is the issue.
Adequate cells, adequate diagnosis.
Thank you.
But to go back to the molecular profiling, so at our institution with Fox Chase and Temple, we have made a small committee or whatever you want to call it with the chief of medical oncology. And we go over every month and we figure out which tumor requires what type of testing. So the medical oncologist will write us and say, if you find lung adenocarcinoma, then you are allowed to do these testing. So we get a blanket permission for reflex testing. So what Wasif said is absolutely correct, that we require permission from the medical oncologist to go and perform molecular testing. But you can have a blanket permission so that you can do reflexly any test. So if you say for pancreatic carcinoma, this is what I want, then once the pathologist makes a diagnosis of adenocarcinoma, we don't have to wait for anybody else to tell us to do the testing. So it saves time in terms of when the patient goes through the procedure, we make a diagnosis, and we immediately do the molecular profiling so that by the time patient reaches VASIF, they will have that process in place.
I think that's kind of very important because, we know that time is really crucial in patient with pancreatic cancer. And, I always tell people that I don't treat cancer, I treat cancer patients. And I think to treat a cancer patient, you need a village. They need a medical oncology, pathologist, nutritionist, palliative care, surgical oncology. Of course, without GI, I cannot diagnose a patient. So I think that's the key element, that if we really come up with a way that we can have like blanket consents or blanket approvals, we can really speed up the process to provide the therapy to the patient in a timely fashion. Not only that helps to improve the outcome for the patient, but also decrease the anxiety for the patient and the caretakers.
I think we are getting ready for our live transmissions from Orlando Regional. But thanks for the symposium. The afternoon symposium on pancreatic fluid collections is going to be unbelievable. This will be a fantastic symposium. So I will hand over the stage to Rob. And thanks for all my panelists for this wonderful session. Thank you.
Thank you.
And also my sincere thanks to Medtronic for sponsoring this symposium.